Good evening, Dr. Phil here. Today we'll be discussing on APRV, Airway Pressure Release Ventilation. Important definitions. Mechanical ventilation is the technique through which gas is moved towards and from the lungs through an external device connected directly to the patient. Positive pressure ventilation is mechanical ventilation in which gas volume is delivered by a positive pressure gradient. Negative pressure ventilation is mechanical ventilation in which a trans-airway pressure gradient is created by decreasing the alveolar pressures to a level below the airway opening pressure. Mechanical ventilation mode is a specific combination of breathing pattern, control type, and operational algorithms. Control variable is the mechanism that provides a mode of ventilation within a specific parameter. Classification includes pressure controller. The ventilator controls the trans-respiratory system pressure, which is airway pressure minus body surface pressure. Volume controller. Volume is measured and used as a feedback signal to control the output delivered. Flow controller. The ventilator directly measures flow and uses flow signal as a feedback signal to control its output. Pressure is allowed to vary with changes in the patient's compliance and resistance while directly measuring and controlling flow. Time controller. Ventilators that measure and control inspiratory and expiratory time. Trigger variable is the variable that determines the start of inspiration. Classification includes time triggered, initiation of a mechanical breath based on the set time interval for one complete respiratory cycle, inspiratory and expiratory time. Pressure triggered, initiation of a mechanical breath based on the drop in airway pressure that occurs at the beginning of a spontaneous inspiratory effort. Flow triggered, initiation of a mechanical breath based on the decrease in return flow to the ventilator that occurs at the beginning of a spontaneous inspiratory effort. Limit variable is the factor that controls the inspiratory flow. The limit variable, pressure, flow, or volume is not allowed to rise above a preset value during the inspiratory time. It may be pressure, flow, or volume limited. For pressure limited breaths, a fixed pressure is delivered over a set time. Caution: the tidal volume will be governed by the lung compliance and may be inadequate or risk volutrauma in situations where compliance changes rapidly. Flow limited breath, a fixed flow is delivered over a set time so that a known tidal volume is delivered. Caution: airway pressure will rise to whatever is necessary to deliver the breath, risking barotrauma. Volume limited breath, a fixed volume is delivered over a set time. Cycle variable is the factor that governs when the change from inspiratory to expiratory phase occurs. Classification may be time, pressure, flow, or volume cycled. For time-cycled breaths, inspiration is terminated after a preset time interval, regardless of whether preset pressure has been achieved or a desired tidal volume has been delivered. For pressure-cycled breaths, inspiration is terminated after a preset pressure is reached. This is rarely used as a primary function, although it may be used as a secondary cycle factor when a high-pressure alarm is triggered. For flow-cycled breaths, inspiration is terminated once inspiratory flow falls to a minimal level towards the end of inspiration. For volume-cycled breaths, inspiration is terminated when the preset volume is attained. General principles of APRV. APRV is a novel form of ventilation first described by Stock et al. In 1987. Indications for APRV includes patients whose lungs are recruitable, i.e., are considered to have collapsed or atelectatic areas of a lung. Patients whose lungs have diffuse disease processes such as ARDS or multifocal pneumonia. Patients in whom prone positioning is contraindicated, or those who have not responded to a trial of prone positioning. Patients in whom a trial of low tidal volume ventilation has failed. Patients at high risk of respiratory deterioration, such as traumatic chest injury, aspiration, inhalational injury, and pancreatitis. Patients with sepsis and multi-organ failure requiring invasive ventilation, and obese patients. Relative contraindications for APRV includes profound cardiovascular instability, particularly if secondary to untreated hypovolemia, severe bronchospasm, untreated pneumothorax, recent pulmonary resection with stable lines or anastomosis, pulmonary hypertension with right ventricular decompensation, bronchopleural fistula, and obstructive lung disease. APRV is a pressure-controlled mode of ventilation that delivers an almost continuous positive pressure, the P high, with intermittent time-cycled short releases at a lower pressure, P low, that allows spontaneous breathing throughout the entire ventilatory cycle at both pressure levels. This diagram shows the basic APRV waveform, showing the inflation and release phases. P high describes the highest level of pressure applied to the respiratory system. It is distinct from terms such as inspiratory pressure used to describe conventional mechanical ventilation to convey the prolonged duration spent at this pressure. It is essentially the CPAP used to recruit alveoli. CPAP is PEEP applied to the airway of a patient who is breathing spontaneously. P high determines the mean airway pressure and determines the pressure gradient of the pressure releases. T high describes the time in seconds spent at P high. The T high to T low ratio determines the frequency of breath releases. P low refers to the lowest pressure applied by the ventilator to the respiratory system and is normally set at 0 cmH2O. T low indicates the time in seconds spent at P low. It is short and titrated such that intrathoracic pressure never reaches atmospheric pressure. APRV delivers mandatory breaths through brief transitions from P high to P low, and then resumption of P high to avoid alveolar collapse. When the high pressure P high level is dropped or released to the low pressure level, it simulates a mechanical exhalation. When the low pressure level is raised to the high pressure level, it simulates an inspiratory mechanical breath. Ventilator requirements to provide APRV. The ventilator must have a high-flow CPAP circuit that has been modified with the addition of a release valve. When the release valve opens, CPAP pressure is vented, circuit pressure drops to 0 or a lower CPAP level. A mandatory inspiration begins when time-triggered closing of the release valve occurs. Airway pressure rapidly increases to baseline CPAP pressure and is maintained for the duration of inspiration as long as the release valve remains closed. The mandatory inspiration ends when time-triggered opening of the release valve occurs. This allows the circuit pressure to decrease as the patient exhales. APRV is a type of inverse ratio ventilation that combines time-triggered, time-cycled, pressure-limited mandatory breaths with spontaneous breaths at any point in the ventilatory cycle. Control is pressure, trigger is time or pressure or flow, limit is pressure, cycle is time. APRV may be considered as an intermittent mandatory ventilation mode with extreme inverse IE ratios that allows unrestricted spontaneous breathing. An intermittent mandatory ventilation mode allows the patient to spontaneously breathe between time-triggered ventilator breaths and may be volume or pressure controlled. The patient may breathe gas at the same FiO2 and baseline pressure without triggering a mandatory breath. Spontaneous breaths may also be augmented by pressure support, which increases spontaneous tidal volume and reduces inspiratory work associated with endotracheal tube resistance. Pressure support is a variation of spontaneous mode of ventilation that augments a patient's spontaneous effort with positive pressure. Pressure support helps to augment the spontaneous tidal volumes in conditions of low compliance and high airflow resistance. APRV modes that add pressure support should have this feature removed, as this will continually adjust the duration of T-low automatically, which will potentially lead to airway collapse. Pressure support of spontaneous breaths when the lungs are inflated has the potential to cause barotrauma and over-distension of maximally recruited lung units. Automatic tube compensation (ATC) should be used instead of pressure support if available. Automatic tube compensation is a mode of ventilation that offsets and compensates for the airflow resistance imposed by the artificial airway and can eliminate the resistance imposed by the artificial airway and allows the patient to have a breathing pattern as if breathing spontaneously without an artificial airway. The ventilator adjusts the pressure to compensate for airway size or flow demands. ATC is active both during inspiration and expiration and may reduce air trapping and intrinsic PEEP. ATC can be applied in all ventilation modes. Inverse ratio ventilation. Indications includes management of hypoxemia refractory to other ventilation strategies, particularly in patients with hypoxemia secondary to ARDS. Contraindications includes conditions that put the patient at higher risk for developing complications such as pre-existing hemodynamic compromise and obstructive lung disease requiring a prolonged expiratory phase. General principles of inverse ratio ventilation. IE ratio refers to the ratio of inspiratory time to expiratory time. In conventional mechanical ventilation, I time is typically lower than E time, so that the IE ratio ranges from about 1 to 1.5 to 1 to 3, and this resembles the normal IE ratio during spontaneous breathing and is considered physiologically beneficial to normal cardiopulmonary function. In inverse ratio ventilation, the traditional IE ratio of 1 to 2 is inverted to 2 to 1 to 4 to 1 and is often used in conjunction with pressure-controlled ventilation. The purpose of IRV is to provide a shortened expiratory phase to permit an adequate tidal volume to escape without allowing alveoli to fall below their closing volume. IRV improves oxygenation by reducing intrapulmonary shunting, increasing VQ matching, and reducing dead space ventilation. Compared with conventional ventilation with PEEP, IRV reduces shunting and increases oxygenation by increasing mean airway pressure and causing auto-PEEP. Changes that may be seen when switching from conventional positive pressure ventilation with PEEP to pressure control inverse ratio ventilation includes increase in mean airway pressure, increase in central venous pressure, increased pulmonary artery pressure, increased PaO2 and PaCO2, and increased intrinsic PEEP, reduced overall PEEP, reduced peak airway pressure, reduced cardiac output, and reduced FiO2 requirement. Adverse effects of inverse ratio ventilation includes increased mean alveolar pressure and volume, accumulation of auto-PEEP, barotrauma, volutrauma, hypoventilation, hemodynamic compromise. Increased mean airway pressure increases intrathoracic pressure, which reduces venous return to the heart, reducing preload, cardiac output, and blood pressure. Hemodynamic compromise may be pronounced in patients who are already preload deficient, i.e. hypovolemia, or having vasodilatory shock, or are in a significant preload dependent state, such as in obstructive shock. Other adverse effects includes worsening of pre-existing pulmonary edema. There is increased rate of transvascular fluid flow or flooding induced by an increased alveolar pressure. Patients receiving IRV are often agitated. They may require sedation and neuromuscular blockers to facilitate ventilation. Sedatives and neuromuscular blockers are associated with various complications such as ICU delirium and critical illness myopathy. APRV versus other modes of ventilation. For IE ratio, in conventional ventilation, it is typically 1 to 4 to 1 to 1. For inverse ratio ventilation, it is more than 1 to 1. For BiPAP, it is 1 to 4 to 1 to 1. For APRV, it is typically more than 2 to 1. For HFOV, it is 1 to 2 to 1 to 3. For mean airway pressure, conventional ventilation is less, IRV is increased, BiPAP is increased, APRV is much increased, and HFOV is much increased. For spontaneous breathing, in conventional ventilation, it triggers a breath. For IRV, it triggers a breath. For BiPAP, spontaneous breathing is allowed at any time of the respiratory cycle. For APRV, spontaneous breathing is allowed at any time of the respiratory cycle as well. For HFOV, spontaneous breathing is usually suppressed intentionally, as this can cause a drop in mean airway pressure. Requirement for heavy sedation and paralytics. For conventional ventilation, it may be required. For IRV, it is usually required. For BiPAP and APRV, it is not required. For HFOV, it is usually required. Auto-PEEP generated For conventional ventilation, it is less common. For IRV, it is common. For BiPAP, it is less common. For APRV, it is very common. For HFOV, it is very common. Additional notes: APRV versus pressure-controlled inverse ratio ventilation. The method of setting the duration of T-low based on expiratory flow characteristics and the promotion of spontaneous ventilation fundamentally differentiates APRV from extreme inverse ratio mandatory ventilation. APRV versus biphasic PAP or BiPAP. BiPAP is a mode that has two baseline pressures, inspiratory pressure and PEEP. It allows spontaneous breathing at any point in the mechanical ventilation cycle. The spontaneous breaths have the option of pressure support ventilation. Biphasic PAP is also called bilevel, BiPAP, bivent, biphasic, PCV1 or dual PAP, depending on the ventilator. BiPAP is similar to APRV with one exception. In APRV, the patient spends most of the time at the high pressure level, with less than 1.5 seconds spent at the low pressure level. In biphasic PAP, the patient spends more time at the low pressure level. However, ambiguity still exists in the criteria that distinguishes APRV and BiPAP. Physiological rationale for the use of APRV. APRV is similar to an almost constant recruitment maneuver, unlike conventional invasive ventilation in which a briefer period of recruitment is used, followed by PEEP to prevent alveolar collapse. APRV maximizes the recruitment of available lung tissue by maintaining a prolonged high pressure, and this improves oxygenation. This is an example of the open lung approach to invasive ventilation. APRV is an open lung mode of invasive mechanical ventilation in which spontaneous breathing is encouraged. The open lung concept of mechanical ventilation refers to the notion of using the ventilator to open the lung and keep it inflated by using maneuvers such as early application of alveolar recruitment, PEEP, and inverse ratio ventilation. Goals: to open the whole lung with the required pressure, to keep the lung open with PEEP levels above the closing pressure, and to maintain optimal gas exchange at the smallest possible pressure amplitude to optimize CO2 removal. APRV uses these techniques in an attempt to reduce alveolar overdistension and prevent alveolar collapse. The open lung concept in the context of a pressure volume curve. This is a pressure volume curve. The lower inflection point, LIP, represents the initial point at which alveoli are most readily recruited, below which alveoli will tend to collapse. The upper inflection point, UIP, represents the point at which alveoli becomes over-distended and thus most susceptible to volute trauma. Theoretically, ventilation strategies would maximize alveolar recruitment and prevent alveolar distension if it operates in the area between the LIP and UIP. However, tomographic studies evaluating lung volumes along these various inflection points on both inflation and deflation limbs show that a point called the point of most curvature is a better marker of de-recruitment than the LIP in the deflation limb of the curve, i.e. LIP is not the actual point of de-recruitment in the human lung. The point of most curvature is higher on the curve than LIP and is similar to the UIP in terms of aeration and recruitment of alveoli in the inflation limb. Short and infrequent periods at a lower pressure enables CO2 clearance. During APRV, the patient is encouraged to breathe spontaneously throughout the respiratory cycle. Benefits of spontaneous breathing during APRV includes facilitation of gas exchange, maximization of continued recruitment of lung tissue. In a passive system, non-dependent lung units are recruited first, followed by dependent units. This risks overdistension of the non-dependent units by increased pressures. Spontaneous ventilation in an active system recruits dependent lung units first through pleural pressure change. Spontaneous breathing promotes venous return to the heart and prevents wasting of respiratory muscles. Ventilation during APRV. Alveolar ventilation and CO2 removal during APRV is facilitated by spontaneous ventilation and intermittent release periods to P low. Other variables that affect alveolar ventilation includes the pressure gradient, which is the difference between P high and P low, the airway pressure release time, T low, and the airway pressure release frequency, where the frequency equals 60 divided by cycle time, where cycle time is T high plus T low. Frequency rather than pressure gradient is often manipulated to improve ventilation. A reduction in T high increases minute ventilation as less time is spent at inflation, and this results in higher frequency of release. Stress and strain. Stress is the applied force encompassing pressure and area change exerted on the lungs during mechanical ventilation. Strain is deformation of the lungs from stress, expressed as the ratio between N inspiratory lung volume and N expiratory lung volume. The amounts of stress and strain are markedly affected by starting lung volume. Stress and strain of ventilating a lung that is homogeneous and fully recruited is less than the stress and strain of ventilating a minimally recruited, collapsed lung, even if the tidal volume achieved is the same. To minimize dynamic strain, the ideal technique for ventilation is one that recruits all available alveoli, inflates the lung to the optimal point on its compliance curve, and maintains an adequate N expiratory volume. In conventional positive pressure ventilation in patients with lung injury, tidal volumes are restricted to reduce lung stress and incremental amounts of PEEP are used to maintain alveolar recruitment during expiration. However, it is often difficult to determine the optimal PEEP to prevent de-recruitment for each patient. APRV reduces dynamic strain by having a dramatically prolonged time at an increased pressure, which increases mean airway pressure and increases N expiratory lung volume. This maximizes alveolar recruitment by providing a longer time to achieve homogeneous ventilation and gas distribution between lung units that have differing compliances. APRV reduces lung de-recruitment by titrating the duration of T low to alter the expiratory flow characteristics which are determined by the lung mechanics of each individual patient. This will be explained further in initiating and titrating APRV section. Theoretical benefits of APRV. Within the broad conceptual framework of APRV as detailed in the previous section, there is no clear definition for the settings that should be termed APRV. This ambiguity has resulted in considerable variation in practice, often complicating direct efficacy and outcome assessments. Inconsistency in application may also explain why many of the theoretical benefits of APRV have not been consistently demonstrated in humans. Two characteristics of APRV account for many of the proposed advantages over conventional ventilation strategies: the provision of near-continuous CPAP and allowance of unrestricted spontaneous ventilation. APRV optimizes ventilation perfusion matching and enables lung protective alveolar recruitment. APRV increases lung recruitment. Airway pressure from P high functions as a hybrid, combining plateau pressure and PEEP level to maintain nearly complete recruitment pressure. APRV resembles a continuous recruitment maneuver that accommodates ventilation with a brief release of the CPAP phase. APRV uses the expiratory limb of the volume pressure curve, and de-recruitment is minimized. Long T high and constant airway pressure supplied at P high ensures that a large number of alveolar units are recruited, even those with a slow time constant. This results in considerable benefit in patients with ARDS, as heterogeneous alveolar collapse is a pathophysiological hallmark of the disease. Sustained high mean airway pressure promotes alveolar recruitment, improves lung homogeneity, and increases FRC. Prolonged duration of P high promotes ventilation through collateral channels, such as pores of Kohn. Ventilation through these auxiliary pathways may recruit additional alveolar units and facilitate the redistribution of alveolar gas volume throughout the lung. APRV ventilation takes advantage of both bulk gas flow and also diffusion of CO2 into the dead space while the lung is held open. This diffusion reduces the dead space, making ventilation more efficient and thereby reducing the necessary minute ventilation. Reducing the minute ventilation reduces the work of the patient needed to expand and also reduces the energy that the lung tissue must absorb during ventilation. APRV reduces athalec trauma. Long T-high and constant airway pressure supplied at P-high causes lung units to be constantly kept open. This reduces cyclical opening and collapse of atelectatic but recruitable lung units and reduces lung injury. Although there is a reduction in airway pressure during the release phase, these periods are short and thus minimize both alveolar de-recruitment and athalec trauma from repetitive alveolar collapse and expansion. As CO2 removal is accomplished during the brief release phase or with spontaneous breathing throughout the CPAP phase, de-recruitment and atelectasis formation are limited. APRV reduces alveolar overdistension. APRV prevents alveolar overdistension by optimally matching lung volume with the volume of delivered gas. P-high is set by the operator, and this reduces the potential of ventilator-induced lung injury from alveolar overdistension. Plateau pressures are not exceeded to accommodate tidal volumes, as ventilation in APRV does not require additional airway pressure above the P-high. APRV does not require an increase in airway pressure above the P-high to augment ventilation, allowing the process of ventilation to be directed away from lung inflation and distension. By contrast, conventional ventilation increases airway pressure, elevating lung volumes and potentially increasing the risk for overdistension. This allows the P-high to remain within the pressure limits considered safe. In a rat model of pulmonary ARDS, compared with the use of volume-controlled ventilation, the use of APRV reduced the expression of amphiregulin, a gene expressed during times of alveolar stretch. Because patients are able to breathe spontaneously, especially at P-high, they can adjust the delivered gas volume by taking larger or smaller breaths whenever needed. This increases ventilation perfusion matching and reduces lung injury caused by pendeluft. Regarding pendeluft, inspiratory and expiratory airflows in healthy lungs are relatively uniform throughout the bronchial tree. However, in pulmonary diseases or under abnormal conditions, this uniform pattern can be disturbed. Inhomogeneous inflation or deflation of the lungs can cause dynamic pressure differences between different regions, which in turn lead to inter-regional airflows. This effect is referred to pendeluft or swinging air because gas is passed back and forth between the different regions of the lungs. During APRV, release ventilation lowers airway pressure and lung volume, reducing the risk of overdistension. APRV reduces peak and plateau pressures while increasing mean airway pressure. APRV can generate lower peak and plateau pressures for a given tidal volume than conventional modes due to the patient's spontaneous ventilatory efforts and intermittent release periods to be low. This reduces the likelihood of inducing villi from generation of dangerously high airway pressures to maintain adequate ventilation. Prolonged time spent in inspiration as a function of the inverted IE ratio causes APRV to generate higher mean airway pressures than conventional ventilation modes. Increased mean airway pressures result in both greater mean lung volumes and higher PaO2 values within a certain physiologic range. APRV permits unrestricted spontaneous breathing. APRV allows for less sedation and paralysis. Reduced need for neuromuscular blockers. As APRV mandates spontaneous ventilation, pharmacologic paralysis should be avoided to maximize the mode's benefits. Avoidance of neuromuscular blockade in critically ill patients reduces the risk of development of critical illness polyneuromyopathy. Although the use of neuromuscular blockers in patients with ARDS has been associated with improvements in mortality and other clinical outcomes, The means by which they achieve these effects remain unknown. It could be due to the minimization of alveolar overdistension and collapse from patient ventilator asynchrony. These mechanisms may be less applicable to patients ventilated with APRV, as APRV allows patients to breathe spontaneously. The allowance of spontaneous breathing reduces the need for deep sedation to achieve patient ventilator synchrony. Reduced doses of opioids and benzodiazepines in the critically ill reduces the incidence of their negative side effects, such as constipation, delirium, and development of tolerance. Patients who are awake and breathing comfortably can participate in physical therapy and mobilization efforts, whereas deeply sedated and paralyzed patients cannot. APRV preserves diaphragm activity. Spontaneous ventilation preferentially exercises the dorsal and lateral aspects of the diaphragm, which causes regional ventilation redistribution to the dependent and well-perfused areas of the diaphragm, and a reduction in hyperinflation of the non-dependent regions in the supine patient. This reduces intrapulmonary shunt and increases ventilation perfusion matching. Spontaneous breathing promotes the expansion of the lungs and chest wall at FRC. APRV prevents diaphragm muscle atrophy associated with prolonged mechanical ventilation due to allowance of spontaneous breathing. APRV improves hemodynamic profiles. Positive pressure ventilation increases intrathoracic pressure during inspiration, and this reduces venous return, right ventricular output, and pulmonary blood flow. Spontaneous breathing during APRV mimics normal negative pressure ventilation, which reduces intrathoracic pressure during inspiration and increases systemic venous return to the heart from the abdominal organs and alleviating pressures on the pulmonary capillaries. These hemodynamic changes can improve cardiac performance and oxygen delivery at the tissue level. Compared with conventional ventilation modes that do not permit spontaneous breathing, the use of APRV has been associated with increased urine output, increased heart rate, increased blood pressure, reduction in vasopressor and inotrope requirements, increased cardiac index, increased lactate clearance, increased arterial oxygenation, increased SCVO2 and SVO2. Theoretical risk of APRV. Volume trauma. Efforts to accurately measure and target tidal volumes are problematic with APRV. APRV as a form of pressure-controlled ventilation carries the risk of volume changes with alterations in lung mechanics and the changes in patients' spontaneous inspiratory effort. This may cause large tidal volume and transpulmonary pressure swings, potentially contributing to volume trauma. Since APRV mode is pressure limited, for a given pressure gradient, the patient's tidal volume will vary directly with changes in lung compliance and inversely with changes in airway resistance. For this reason, the exhaled tidal volume should be closely monitored to prevent hyperinflation. Superimposition of spontaneous tidal volumes on the top of the mandatory breath may increase the likelihood of stretch-related injury. Large exhaled volumes imply potentially large end inspiratory volumes that might obviate the desired lung protective strategies, with potential increase in ventilator-induced lung injury and possibly mortality. There is also a theoretical concern of dynamic hyperinflation when using APRV in patients with COPD or air trapping conditions who require prolonged exhalation time, although there are no conclusive data. It is difficult to attempt to mirror ARDS net tidal volume limitation of 6 mL per kg. Animal and human trials conducted so far do not support titrating APRV to a particular mil per kilogram tidal volume target. Applying one specific element of a mandatory mode of ventilation care bundle in the ARDS net study to a different paradigm of spontaneous ventilation, such as APRV, might not be valid. The next risk is barotrauma. In practice, plateau pressure may be difficult to measure, thus it may be unknown whether the safe limit plateau pressure of 30 cm H2O is exceeded. Therefore, many clinicians target a peak inspiratory pressure of 30 cm H2O or less in these patients. Atelectrauma. Alveolar collapse due to inappropriately prolonged T-low, accompanied by reinflation of alveoli during P-high, may result in repeated collapsing and reopening of alveoli and shear stress. Occult atelectrauma still occurs with APRV. T-low times longer than 0.2 seconds could still result in collapse of injured alveoli, and many ventilators are unable to provide T-low times this short. Increased work of breathing. Spontaneous breathing efforts increases oxygen consumption by the respiratory muscles, which may exceed 25% of total body oxygen consumption. Increased perfusion of respiratory muscle may drive systemic perfusion and oxygen delivery away from vital organs, which can be deleterious, especially in shock states. Hypoperfusion of the GI tract facilitates translocation of bacteria into the systemic circulation. Spontaneous breaths that occur at P-low or during the pressure release transition from the P-high to P-low have higher work of breathing. Spontaneous breaths that occur at P-high should have the least amount of work of breathing unless an excessive level of pressure is used, causing lung over distension that paradoxically increases the elastic work of breathing. The next risk is patient ventilator desynchrony. This may result when pressure release from P-high to P-low occurs during spontaneous inspiration, as mean airway pressure would be decreasing and gas flow would be escaping the circuit just as the patient was trying to inspire. Patient ventilator desynchrony may also occur when pressure increase occurs during spontaneous expiration. Due to desynchrony, this might be an argument in favor of synchronizing mandatory breath cycling with a spontaneous expiration during T-high. The timing of pressure release and pressure increase should be in accordance with the patient's breathing pattern to avoid patient ventilator desynchrony. The next risk is exposure to high transpulmonary and transvascular pressures. Spontaneous breathing during T-high can cause high local transpulmonary pressures and tachypnea, especially in the context of heterogeneous lung disease. This increases the risk of patient self-inflicted lung injury. The breathing efforts may increase the transcapillary pressure gradient, enhancing pulmonary edema formation. The impact of spontaneous breathing on pulmonary edema formation during APRV is potentially dependent upon the P-high level and IE ratio employed. Hypercapnia. A portion of the minute ventilation during APRV is provided by the small number of pressure release cycles per minute during T-low. Thus, a substantial amount of minute ventilation, occasionally up to 70%, may be abruptly shifted to the patient to create the baseline minute ventilation. Inadequate VE could result in acute increase in PaCO2, increased respiratory drive, and increased work of breathing. Thus, the potential options to decrease work of breathing while maintaining minute ventilation are to reduce the time ratios, which usually maintains both the mandatory minute ventilation and the lung protective ventilation. The high inflation time and oxygenation can be potentially sacrificed. Other options to decrease work of breathing while maintaining VE are to increase cycle frequency and increase mandatory breath volumes. Effects of APRV on the cardiovascular system. APRV increases intrathoracic pressure. Negative effects includes reduction of venous return to the right side of the heart, increased afterload, and increased pulmonary vascular resistance, which might worsen right heart failure. Positive effects of increased intrathoracic pressure includes reduction in transmural left ventricular pressure, resulting in reduced work of contraction and increased cardiac output. In the context of hypoxemia, a mode of mechanical ventilation that increases arterial oxygenation increases myocardial oxygen delivery, myocardial function, and increases cardiac output. As APRV allows spontaneous breathing, there is reduced requirements for sedative drugs. This reduces the requirements for vasoactive drugs and results in improvement of the hemodynamic state. Multiple complex cardiorespiratory interactions makes it difficult to predict which patients will have an adverse cardiovascular response to APRV. One approach is to offer a trial of APRV to patients with severe respiratory failure and use echocardiographic assessments of left and right ventricular functions before and after the initiation of APRV. If there is arterial hypotension after initiating APRV, consider a 250 to 500 ml bolus of IV fluids to attempt to restore cardiac output. Echocardiography should be used to guide the management of persisting hypotension. It is important to always choose the most appropriate mode of ventilation for each patient. Evidence base for APRV. For over 3 decades, APRV has remained a mode of ventilation often reserved for cases of refractory hypoxemia. Because of the potential for improved alveolar recruitment without over-distension offered by APRV, this mode of ventilation has been extensively studied as an alternative to other ventilation strategies. Despite its physiologic advantages over other ventilation modes, its benefits have not been consistently demonstrated in patient populations. Although data on the use of APRV for ARDS appears promising, there is a lack of large randomized controlled trials showing consistent benefits. This may be due to the lack of a standardized definition of APRV, as well as considerable variability in the settings and parameters implemented in different trials. Despite the large number of trials evaluating its effectiveness, there remains a dearth of information describing APRV initiation and titration recommendations. While some described settings are based on clinical trials, others are based on expert opinion alone. There are no direct comparison studies of APRV strategies that have been performed, and thus a single best titration strategy cannot be recommended. There is no consensus on the optimal APRV strategy, and one potential reason for the inconsistency of outcomes is variability in the approach to initiating and titrating encountered in the literature. Two of the most commonly described evidence-based approaches are those proposed by Habashi and Zhou. These two specific protocols have their foundations backed by nearly 50 years of basic science research. Many trials of APRV were conducted before the ARDS-NET trial, which demonstrated reduced mortality with lower tidal volume ventilation compared with higher tidal volume ventilation, and thus did not compare APRV to current best practice for mechanical ventilation. Therefore, the historical evidence base must be interpreted with caution. Noteworthy studies. In animal models, APRV improves arterial oxygenation, increases ventilation-independent areas of the lung, reduces inflammatory cytokine production, and can prevent the development of ARDS. Studies that have shown this includes Herring R. et al. In 2005, Newman P. et al. 2005, Albert S. et al. 2011, Emmer B. et al. 2013, and Roy S. et al. 2013. In a study by Roy et al., pigs with induced sepsis were randomized to receive APRV or ARDS-NET protocol, low tidal volume ventilation. When compared with APRV group, pigs in the low tidal volume ventilation group had reduced concentrations of surfactant protein A, inferior gas exchange, and poorer post-mortem histological appearance of the lungs. Human studies. A study by Andrews P.L. et al. In 2013, which is a large retrospective systemic review of 66,199 patients in North American trauma centers, showed that the early use of APRV in a single center was associated with lower incidence of both ARDS and mortality than conventional ventilation in other centers. Regarding the study by Zhou et al. In 2017, this is the most successful human randomized controlled trial to date using APRV. It was a prospective randomized controlled trial of 138 patients randomized to receive APRV or low tidal volume ventilation based on the ARDS network recommendations. Patients were randomized to receive APRV or LTV early in the course of their disease. Compared with low tidal volume ventilation when implementing the Zhou's APRV titration strategy, the authors found that patients had significantly fewer ventilator days, increased chances to be extubated, reduced need for a tracheostomy, increased oxygenation and respiratory compliance, reduced plateau pressures, reduced sedation requirements, shorter ICU length of stay, and similar hemodynamic variables. A non-statistically significant difference in ICU mortality was observed in the APRV group compared with the low tidal volume ventilation group. However, this study was not powered for this outcome. Critics for this study includes the small study size raises concerns about poorly matched groups, with the control group having more patients with comorbidities, a higher incidence of vasopressor support, and pneumonia as the cause of their ARDS. The single-center characteristic of the trial potentially reduces external validity. Sedation management was different between the two groups as well, making it difficult to draw comparisons regarding sedation requirements. The specific protocol used within a given mechanical ventilation mode is the key to determining whether a ventilation strategy is protective or injurious. The ARDS network study in 2000 concluded that it was not that the assist control volume control ventilation mode itself is injurious, but that low tidal volume ventilation is superior to higher tidal volume ventilation in the ARDS patient population, resulting in decreased mortality and increased the number of days without ventilator use. It has now become standard practice to try to minimize ventilator-associated lung injury by using lung protective ventilation, which consists of plateau airway pressures limited to 30 cm H2O by means of a reduced tidal volume, typically 6 mL per kg predicted body weight, to avoid over-distension of alveoli, the use of PEEP, which is essential for alveolar recruitment and prevention of atelectasis trauma, for maintenance of alveolar volume, and for prevention of radial stress associated with cyclical and expiratory collapse and re-expansion at low lung volumes. Permissive hypercapnia is a key part of the current ventilation strategy. Safety of permissive hypercapnia. There are experimental data to suggest that it is safe up to PaCO2 of 9 kPa or 67 mmHg and a pH of 7.2. The degree of hypercapnia and respiratory acidosis tolerated by each patient differs. Many patients tolerate decreases of pH up to 7.2. However, there are groups of patients that will not tolerate even moderate degrees of hypercapnia, such as patients with neurocritical conditions, coronary artery disease, congestive heart failure, arrhythmias, pulmonary hypertension, right ventricular dysfunction, and significant hypovolemia. Benefits of hypercapnic acidosis. Hypercapnia might confer some protection in the context of lung injury and associated systemic organ damage. Hypercapnic acidosis attenuates ventilator-associated lung injury, particularly that associated with volute trauma rather than atelectasis trauma. Myocardial protection. Hypercapnia has some myocardial protective effects. Although a PaCO2 of more than 10 kPa does depress myocardial contractility, cardiac output can still increase as a result of decrease in systemic vascular resistance. Hypercapnia attenuates reperfusion brain injury and delays hepatocyte cell death, and also reduces inflammation. Hypercapnic acidosis modifies some key components of the inflammatory response such as TNF-alpha and IL-1. It reduces lung neutrophil recruitment as well as free radical production and oxidant tissue injury. In particular, hypercapnic acidosis attenuates damage mediated by xanthine oxidase, a complex enzyme system whose production is increased during periods of tissue injury and which is a potent source of free radicals in the lung. However, its anti-inflammatory properties may also limit host response to live bacterial pathogens because free radical production is central to bactericidal activity of neutrophils and macrophages. This may be problematic with ongoing bacterial sepsis. APRV and COVID-19. Based on the review article by Grassali et al. In 2021, available data show that in mechanically ventilated patients with COVID-19, respiratory mechanics and mechanical ventilation settings within 24 hours from ICU admission are heterogeneous, but similar to those reported for classical ARDS. However, to date, complete data regarding mechanical properties of respiratory system, optimal settings of mechanical ventilation, and the role of rescue treatments for refractory hypoxemia are still lacking in the medical literature. APRV versus prone ventilation. Prone ventilation reduces mortality in moderate to severe ARDS in multiple studies. For example, a study by Gurin C. et al. In 2013, which was a multi-center RCT, demonstrated a reduction in 28-day mortality from 32 to 16%. Prone positioning should be a standard of care in all patients with ARDS and a PF ratio of less than 150 mmHg. Prone ventilation should be the strategy of choice before commencing APRV for severe hypoxemia in ARDS wherever possible. APRV cannot be recommended as an alternative to the prone position in the management of severe hypoxemia in ARDS unless when prone positioning is contraindicated or when a trial of prone positioning has failed to improve gas exchange. APRV can be initiated when the patient is in the prone position. This is achieved in a similar way to patients who are supine. However, achieving spontaneous breathing in a patient in prone position can be challenging, as care must be taken to ensure a safe depth of sedation. APRV for neurocritical care. Avoidance of hypoxemia is a key component to neurocritical care and anesthesia. Traumatic brain injury or increased ICP is often considered to be a relative contraindication to the use of APRV. Two retrospective case studies using APRV in hypoxemic patients with traumatic brain injury and ICP monitoring in situ have not shown a detrimental effect on ICP. The case series are by Fletcher J.J. et al. In 2018 and Egerton C. et al. In 2019. Increased arterial oxygenation can often reduce a raised ICP. Permissive hypercapnia is not acceptable to avoid increased ICP. To maintain normal carbia, one method is to note the minute volume with conventional ventilation required to maintain the target arterial carbon dioxide tension before switching to APRV, and then immediately titrate settings to maintain this minute volume. If this is impossible to achieve, ventilation is re-established with a more conventional mode, and other methods of improving hypoxemia should be attempted. As at present there are no large data sets of the use of APRV in traumatic brain injury, consider only using APRV when ICP monitoring is in place to allow determination of any positive or adverse effects on ICP and cerebral perfusion pressure. Kindly refer to the study by Fredericks et al. In year 2020 for a comprehensive discussion of the evidence base of ARDS since the 1990s. Initiation and titration strategies for APRV. Introduction. Similar to the commencement of conventional mechanical ventilation, the settings will depend upon the patient condition and the preferences and experience of the clinician. Airway. All patients should already have a cuffed tracheal tube or tracheostomy tube in situ. Monitoring. Apart from standard vital signs and SpO2, patients should also have invasive arterial monitoring in situ with rapid access to vasopressors and IV fluids. Sedation and neuromuscular blockade. Ideally, patients should be sedated to a degree sufficient to tolerate the tracheal tube only and be breathing spontaneously. However, often patients who may benefit from APRV are deeply sedated and receiving neuromuscular blockers in an attempt to optimize their gas exchange. Consider initiating APRV concurrently with cessation of neuromuscular blockade. Sedative drugs can then be weaned once monitoring has demonstrated no residual neuromuscular block. The choice of sedative drugs should be tailored to each individual patient. An approach that uses drugs with a short duration of action can make titration and promotion of spontaneous ventilation easier. APRV titration strategies are generally categorized as fixed APRV and personalized APRV. For fixed APRV, many of the older APRV studies have implemented the fixed APRV strategy. P-high is typically less than 80% of the respiratory cycle, and T-low is not titrated based on physiologic lung parameters. In personalized APRV, 90% of the breath cycle is spent at P-high. Subsequent titration of T-low is based on lung mechanics to maintain intrinsic peak. More commonly used in recent years, although not uniformly across studies, there are generally two schools of thought, one advocating a short T-low with a P-low of 0 cmH2O to prolong inflation-deflation ratio and create autopeak, while the other school of thought is to use longer T-low to eliminate the autopeak and use a higher P-low to avoid alveolar collapse. There are very few data to support either school of thought. In theory and mathematically, both strategies may be equivalent. Examples of personalized APRV protocols includes the Habashi and the Zhou Protocol. P-high. Problems with excessive P-high includes lung overdistension and impairment of hemodynamics by causing cor pulmonale. Problems with inadequate P-high includes lung de-recruitment resulting in hypoxemia and repeated opening and closing of alveoli causing athalec trauma. Inadequate P-high may cause inadequate ventilator support and increased work of breathing. P-low. Problems if P-low is too low. Atelectasis may occur if autopeep is inadequate to spleen the alveoli open. Exhaled tidal volume may exceed the accepted standard of care, which is 6 to 8 mL per kg. Problems if P-low is too high. A reduced P-high to P-low gradient may result in inadequate expiratory flow, inadequate ventilation, and potential for hyperinflation and volume trauma. T-high. Problems if T-high is too short. Too many releases may lead to de-recruitment of the lung by lowering mean airway pressure. APRV stops being lung protective and starts to resemble generic pressure control ventilation. Problems if T-high is too long. Too few releases may cause hypercapnia. Released breaths are what provides mechanical support to assist the patient's work of breathing. If T-high is too long, the ventilator isn't doing much to support the patient's work of breathing, and this starts to resemble CPAP. T-low. Problems if T-low is too short. The released breath is too small, leading to ineffective ventilation. The ventilator does little to support work of breathing. This isn't generally a major problem, so when in doubt, it's generally better to err on the side of setting the T-low too short. The released breath is too small. This may increase gas trapping and may lead to dynamic hyperinflation and volume trauma under certain conditions, such as obstructive lung diseases. Problems if T-low is too long. The released breath becomes too large, causing de-recruitment, leading to hypoxemia and hypercapnia. Repeated closing and opening of alveoli during released breath causes trauma to the lungs, athalec trauma. This is potentially a huge problem, and frankly it is the Achilles heel of APRV. Fortunately, this is avoidable with adequate monitoring and keeping T-low on the shorter side. The Habashi Protocol. Goals of the Habashi Protocol. Specific initiation and titration goals are set based on the etiology of the patient's respiratory failure. For acute restrictive lung disease, increase or recruit and maintain lung volume by P-high and T-high. Decrease elastic work of breathing with CPAP via P-high and T-high. Automatic tube compensation set at 100% to maximally compensate for artificial airway resistance and decrease resistive work of breathing imposed by the artificial airway. In vitro resistance may be greater than in vivo resistance calculations and measurements due to deformation, kinks, and secretions in the artificial airway. Minimize number of releases to supplement ventilation from spontaneous breathing. Limit de-recruitment. T-low set to ensure that TPEFR is between 50 and 75%. Allow spontaneous breathing within 24 hours of APRV application. For acute obstructive lung disease, the goal is to decrease lung volume, maintain P high at or 1 to 2 cm H2O above intrinsic PEEP, minimize number of releases to supplement ventilation from spontaneous breathing, and to stint airways, T-low set for 25 to 50% of TPFR. Allow spontaneous breathing within 24 hours of APRV. This may require a brief course of non-depolarizing neuromuscular blockade to control high spontaneous breathing frequency and artificial airway contribution to dynamic hyperinflation. Setup. For newly intubated adults, P high is set at the desired plateau pressure, typically 20 to 35 cm H2O. P high of 35 cm H2O or more may be necessary in patients with decreased thoracic or abdominal compliance or morbid obesity. With a P high of 25 cm H2O or more, use of non-compliant ventilator circuit is recommended to minimize circuit volume compression. P low is set at 0 cm H2O, T high is set at 4 to 6 seconds, T low is set at 0.2 to 0.8 seconds for restrictive lung disease, and 0.8 to 1.5 seconds for obstructive lung disease. If the adult is transitioned from conventional ventilation, P high is set at the plateau pressure in volume cycled mode or peak airway pressure in pressure cycled mode. P low is set at 0 cm H2O, T high is set at 4 to 6 seconds, T low is set at 0.2 to 0.8 seconds in restrictive lung disease and 0.8 to 1.5 seconds in obstructive lung disease. If the adult is transitioned from HFOV, P high is set at the mean airway pressure on HFOV plus 2 to 4 cm H2O, P low is set at 0 cm H2O, T high is set at 4 to 6 seconds, T low is set at 0.2 to 0.8 seconds for restrictive lung disease and 0.8 to 1.5 seconds for obstructive lung disease. Use a non-compliant ventilator circuit. The setup for pediatric patients and neonates are included here for completion. Measures to improve oxygenation. Optimize end expiratory or release lung volume. Reassess release lung volume to ensure that TPFR is between 50 and 75%. If oxygenation is poor and TPFR is less than 50%, decrease release time until TPFR is 75%. This is done by examining the flow time graphical display on the ventilator. If the expiratory flow terminates at less than 75% of peak expiratory flow, shorten T low by steps of 0.1 seconds until the flow terminates at 75%. Other measures to improve oxygenation includes optimize gas exchange surface area by adjusting the mean airway pressure, increase P high or P high and T high simultaneously, adjustment of P high to recruit the lung by achieving threshold opening pressure. Adjustment of T high increases gas mixing and recruits lung units with high resistance time constants. Optimize hemodynamics to optimize oxygenation. Measures to improve ventilation. Assess for oversedation or neuromuscular blockade. Stop neuromuscular blockers and gradually reduce sedatives to encourage spontaneous breathing. The use of short-acting sedatives allows for easier titration. Consider using a sedation scale. Optimize end expiratory or release lung volume. Reassess release volume to ensure it is at 50 to 75% of TPAFR. If TPAFR is 75% or more and oxygenation is acceptable, consider increasing T low by 0.05 to 0.1 second increments to achieve 50% TPFR. If TPFR is 50% or less, decrease T low to achieve minimum TPFR of 50%. Increase alveolar ventilation to improve ventilation by increasing P high or P high and T high simultaneously. Increase ventilation by increased minute ventilation, decrease T high and increase P high simultaneously. However, be cautious when increasing the minute ventilation by decreasing T high due to the resultant reduction in mean airway pressure and de-recruitment that can be accompanied by this maneuver. However, this process can be counteracted by simultaneously increasing P high and dropping T high. Weaning. Simultaneously reduce P high and increase T high for a gradual reduction of mean airway pressure and to increase the contribution of spontaneous to total minute ventilation. Progress to CPAP with ATC when P high is 16 or less and T high is 12 to 15 seconds or more, i.e. APRV is 90% CPAP. Wean CPAP with ATC and consider extubation when CPAP is 5 to 10 cmH2O. Precautions. Adjustment of T-low differs with lung disease, lung volume, and artificial airway size. T-low values provided are typical but not absolute. If minute ventilation is increased by decreasing T-high in an attempt to improve CO2 clearance, mean airway pressure and gas exchanging surface area will be reduced. More so if P-high is not simultaneously increased, as CO2 may paradoxically increase. There may be a need to decrease T-low as T-high reduction may produce less mean alveolar volume and will result in shorter emptying time. T-low should not be extended solely to lower CO2 as this may lead to airway closure and lung de-recruitment. T-low should not be viewed as an expiratory time as the patient may exhale throughout the respiratory cycle. Additional notes. FiO2. Initially set FiO2 at 1, but this can be usually reduced rapidly. P-low. A P-low of 0 is selected to allow a larger pressure gradient and to maximize peak expiratory flow rate during the release. P-low is not set more than 0 because the inherent airway resistance will create auto-PEEP. A concurrent short T-low creates intentional gas trapping to maintain an expiratory lung volume. Limitations. The disadvantage of setting P-low empirically at 0 cmH2O and depending on generating auto-PEEP to avoid lung collapse are that tidal volume cannot be controlled independently of an expiratory lung volume, as with conventional ventilation, and even small changes in lung mechanics can cause large changes in both variables. Caution has to be exercised, taking into account that the resultant tidal volume may be highly variable and may be higher than the accepted standard of care, 6 to 8 mL per kg, due to contribution of the patient's spontaneous inspiratory effort. Auto-PEEP may be highly variable and be an unreliable way of avoiding alveolar collapse in contrast to applied PEEP. The amount of auto-PEEP generated is highly variable and depends on the set P-high, set T-low, respiratory system elastance, and resistance, all of which changes frequently during mechanical ventilation. The actual level of auto-PEEP is also difficult to measure. Regarding T-high, T-high is set to 80 to 95% of the cycle time. T-low. It has been demonstrated in a lab setting that adjustment of the T-low to terminate at 75% of PEFR resulted in only 10% variation of alveolar volume between an inspiration and the release phase. Conversely, when T-low was adjusted to a percentage of less than 75% of PEFR, the alveolar volume change between an inspiration and the release phase increases. Alveolar instability and collapse is seen using alveolar microscopy. 0.35 to 0.6 seconds may represent a more appropriate initial T-low setting in adults based on the study by Andrews P. et al. In 2013. In patients with severe ARDS, it has been argued that operators should maintain an EEFR to PEFR ratio of 0.75 based on a study by Neiman GF et al. In 2017. Automatic tube compensation has been discussed in a previous section. Other strategies to consider to improve gas exchange in the critically ill includes prone ventilation, inverse ratio ventilation, high-frequency ventilation, and extracorporeal membrane oxygenation. Next, we discuss the Zhou Protocol. Initiation of settings. Under the original ventilation with VCV mode, measure P plateau, airway resistance and compliance parameters. P high is set at the last P plateau, maximum 30 cmH2O. P low is set at 5 cmH2O to prevent atelectasis. To set the T low, The first step is to calculate the time constant, which is resistance times compliance, and initial T low is set at 1 to 1.5 times time constant. The second step is to titrate T low to 50% or more PEFR. The third step is further titration of T low to achieve the angle of expiratory flow deceleration at 45 degrees on the flow time curve if tidal volume is acceptable. Release frequency is set at 10 to 14 frequencies per minute. FiO2 is set as the same as the prior mode, or 100%, and reduced to 60% as tolerated. Target spontaneous respiratory level. For mild to moderate ARDS, target 30 to 60% of total minute ventilation and the absence of dyspnea. For severe ARDS, target 10 to 30% of total minute ventilation and the absence of dyspnea. Titration of APRV is according to respiratory mechanics, ventilation parameters, arterial blood gas analysis, and hemodynamic parameters. Management of hypercapnia. Ensure that the patient is not oversedated and achieve the spontaneous ventilation level. Increase release volume. Increase delta P, which is P high minus P low. Increase P high by 1 to 2 cmH2O increment, maximum 30 cmH2O, or decrease P low by 1 to 2 cmH2O as necessary. Prolong T low by 0.05 to 0.1 seconds to achieve 50% of PEFR. Improve release minute ventilation by increasing release frequency. Increase release frequency by 1 to 2 rate per increment, maximal 30 frequencies per minute. Severe hypercapnia occurs when pH is less than 7.2 and PaCO2 is more than 60 mmHg. Increase delta P and simultaneously increase release frequency. If hypercapnia is not responsive to all the above adjustments, transmit APRV to other treatments. Management of hypoxemia. Increase P high by 1 to 2 cmH2O per increment, maximal 30 cmH2O. If without CO2 retention, prolong T high. Decrease T low by 0.05 to 0.1 seconds. Increase P low by 1 to 2 cmH2O as necessary. Decrease release frequency by 1 to 2 rate per decrement. Combine recruitment maneuver or prone position. With severe CO2 retention, improve minute ventilation. Ensure sedation and spontaneous ventilation is at target level. Increase FiO2. If hypoxemia is still not responsive to all the above adjustments, transmit APRV to other treatments. P low, T low, T high, and T low and FiO2 are titrated based on interpretation of measured respiratory mechanics at least twice a day. For example, by assessing expiratory flow waveform, respiratory system compliance, airway resistance, release volumes, total minute ventilation, spontaneous ventilation, PEEP, P-peak, P-plateau, arterial blood gases, chest imaging, and bedside ultrasound. Additional notes. Not all ventilators will calculate airway resistance, and this may be manually calculated using the formula peak airway pressure minus P-plateau divided by peak inspiratory flow rate. The use of time constant to initially set T low is considerably different than the method proposed by Habashi. Definition of time constant. Time constant is the time taken for the value of an exponential to fall to 37% of its previous value. An exponential process is said to be completed after 3 time constants. At this point, 94.9% of the process has occurred, or 5 half-lives. At this point, 96.875% of the process has occurred. The time constant is calculated as the product of static respiratory compliance and resistance, both of which are easily obtained at the bedside. The notion of using time constants stems from the concept that pressure, flow, and volume all decay at the same rate according to the same time constant, assuming a simple single compartment model of the respiratory system. During each time constant, each variable changes by 63.2%. Calculating the time constant allows a theoretical estimate of the amount of auto-PEEP generated. In APRV, this resultant value is the intrinsic PEEP of the respiratory system. For each time constant, the pressure, which is the P high setting in APRV, will decay to 63.2% of its previous value. For example, after one time constant, alveolar pressure is 36.8% of its initial value. After two time constants, it is 13.5%. After three time constants, it is 5%. And after four time constants, it is 1.8%. Therefore, if P high is 30 cm H2O and P low is 0 cm H2O, and T low is set at one time constant, then the expected auto-PEEP is about 11 cm H2O at one time constant, 4 cm H2O at two time constant, 1.5 cm H2O at three time constant, and so on, theoretically till infinity if no breath follows. Usually 4 to 5 times the expiratory time constant is needed to eliminate auto-PEEP. The airway pressure release time is usually set at around 1 time constant. As complete emptying requires 4 time constants, this short release time results in a degree of auto-PEEP which further reduces alveolar collapse. However, this calculation of intrinsic PEEP may be inaccurate, often underestimating the intrinsic PEEP as seen in a previous lung simulator model. This is probably due to the fact that this model does not account for the effect of the time constant on the mechanical properties of the expiratory limb of different ventilators. As the time constant changes frequently during mechanical ventilation, a guaranteed alveolar pressure may not be maintained. Thus, following this initial setting of T low based on the time constant, the operator following the Zhou Protocol would further titrate T low to maintain an EEFR to PEFR ratio of 0.5 as previously discussed. Further titrations of T low to be accomplished by viewing the flow time curve on the ventilator to achieve an angle of expiratory deceleration of 45 degrees. Another concern is that even with a very short T low, alveolar de-recruitment may still occur. Other strategies. Some authors recommended constructing a patient pressure volume curve and subsequently setting the P high below the upper inflection point and the P low above the lower inflection point of the inspiratory limb of the curve to avoid ventilator-induced lung injury. However, clinicians are faced with the technical difficulties of obtaining a clear curve, and patients often have to be heavily sedated or paralyzed to obtain a passive breath. There is controversy in the literature regarding the benefits of this method in determining optimal PEEP, as well as how to interpret pressure volume curves. New ventilators, such as the Hamilton G5 and Draeger Infinity, have integrated software tools that facilitates this task. Other authors have set the P high and P low according to oxygenation and ventilation parameters. This method is totally empirical and discouraged as it does not take account lung volumes or pressures. Newer research has looked into titrating P low and T low to achieve a protective tidal volume of 4 to 6 mL per kg in compliance with ARDS network recommendations. However, this method is difficult to achieve in spontaneously breathing patients as effects on tidal volume during releases will be variable. Each tidal volume also varies with changes in lung mechanics. Additional notes for weaning from APRV. Begin by reducing FiO2. Once FiO2 is reduced to 0.4 to 0.5, start to reduce P high. Reduce P high by 2 cm H2O every 2 to 6 hours while maintaining FiO2 at 0.4 to 0.5. If this causes hypoxemia, increase P high by 4 cm H2O and wean more slowly. Once P high is at 20 cm H2O, increase T high by 1 to 2 seconds each time P high is decreased. Continuing this will wean the patient to CPAP of 10 cm H2O or less with minimal releases, allowing a treating clinician to assess patient's readiness for extubation. Alternatively, once P high is 12 to 15 cm H2O with FiO2 of 0.4, the patient can be switched to a conventional pressure-supported mode, setting PEEP at the level of P high with a low level of pressure support, such as 5 cmH2O, and wean conventionally from there. Troubleshooting with APRV. If there is hyperoxemia, reduce FiO2 first. Once FiO2 is at 40 to 50%, start to reduce P-high. If there is hypoxemia, increase P-high by 2 cmH2O intervals, maximal 30 cmH2O. Increase T-high by 0.5 to 1 seconds. If T-high is more than 10 seconds, consider reducing T-low by 0.2 seconds. Increase FiO2. Hypercapnia. Tolerate hypercapnia if pH is more than 7.25 and there are no adverse effects of acidosis. Ensure that the patient is making spontaneous ventilatory effort and aim to reduce sedation further to enhance this. Ensure that ATC is set at 100% with the correct tracheal tube size. Decrease T-high by 0.2 seconds down to a minimum of 3 seconds. Check that the ventilator circuit and heat and moisture exchange filter are free of secretions or excessive moisture. Consider increasing P-high to maximize recruitment and minimize dead space. If hypocapnia occurs, assuming adequate cardiac output, increase T-high by 0.2 seconds. If oxygenation is adequate or excessive, decrease P-high. Hypotension. Administer fluid bolus of 250 to 500 ml of crystalloid. Adjust or initiate vasoactive medications. Consider echocardiography to assess filling status and biventricular function. If gas exchange does not improve with these measures within the first 4 to 6 hours of commencing APRV, the patient will probably not benefit from APRV. Switching to conventional pressure assist mode of ventilation if required. Remove ATC if applicable. Switch to PEEP of 12 to 15 cmH2O with a pressure support of 10 cmH2O. Transfer of patients receiving APRV, for example, for a scan or procedure. Options include transferring while the patient is still connected to the ICU ventilator if possible, or choosing a portable ventilator that can deliver APRV. A brief period of conventional ventilation may be considered, accepting the risk of de-recruitment and subsequent hypoxia. It is important to keep PEEP high, for example, a minimum of 15 cmH2O, when temporarily switching to conventional ventilation to minimize lung de-recruitment. These are my references. Thank you.